Well, good morning, everyone. I want to thank everyone for being here. Again, I'm Lisa Selowitz. I'm staff counsel here at the Ohio Department of Mental Health and Addiction Services. And before getting our meeting underway, I just thought I'd go over some few housekeeping things to ensure that we can all hear each other. For the work group members who are attending in person, as you know, please join the meeting through Teams. And while doing so, please keep your laptop speaker and your Teams audio muted so that we prevent sound feedback. And for those of us sitting further from the white microphone there on the center table, I ask that you use the microphones that are distributed around the table. That way we can hear each other and get a better recording. And to use the microphones, you just simply press the black button on the front, and then when you're finished, press it again. Okay. And then for our members who are attending virtually, please make sure your computer audio is turned on and that you use your Teams mute and unmute button to participate in the meeting. And then all work group members, please leave your Teams video on as you feel comfortable, but especially when you're speaking. Members of the public and media who are joining us virtually via Teams, please make sure your audio is turned on to hear the meeting. If you have any difficulty joining virtually, you may dial in by phone through the telephone number that's on the screen and using that passcode. If you are a member of the media, please put your name and organization in the chat box. So all public participants will be in listen-only mode. However, there will be a public opportunity to comment at the end of the meeting, and all comments and questions can be submitted through the chat function or emailed to the 340 Review Workgroup at mha.ohio.gov email address. Closed captioning is also available to all the Teams participants through the Turn Live Captions On function, which is under the ellipses icon in the top right-hand corner of your screen. Next slide. So this is the agenda that was sent to you in advance and which we will follow today. But before getting into the short presentation on the 340 Workgroup survey results, I'd like to turn it over here to Director Chris for her comments regarding the Governor's State of the State address.
Good morning, everyone. I'm so glad that all of you were able to be here, either in person or virtually. Really looking forward to the conversation today. And I did want to highlight the State of the State. I hope all of you were able to see the State of the State, either while it's happening or watch it afterwards. The governor spent 10 minutes out of his hour-long address talking about mental health and the vision for what mental health and addiction services should be in the state of Ohio. And the opportunity that creates for this work group, for all of us together as a system, is tremendous. And so just thinking about the areas that he really highlighted in terms of building a strong workforce, building on that full continuum of care, specifically around crisis and outpatient services, residential recovery supports, prevention, that whole community-based set of services that has never really been fully built. And then also the focus on data and research and innovation and making sure that Ohio's citizens are getting the best possible services and that the best outcomes so that they can live their full purpose. It was, I think, a really exciting day for him to share that vision with all of us, and really, you know, as much opportunity as it creates a lot of expectation for us as a system as well. And so as I was thinking about this work group today, I really wanted to just echo that vision that he's shared and help us stay focused on that as we really look at what's best for the people of Ohio. You know, that's what we started with last time. We'll continue to do that and Today's conversation is meant to go through the themes that came out, to get your reaction to those, look at the agendas we have laid out in the process, and then dive into some of the work today as well. So I'm really looking forward to building the preferred system with all of you, and to looking at this section of the statute to see how it can help encourage us and support us in that work. And one more note. I'm going to have to leave a little bit early, and I apologize for that, but I have an obligation with the governor's office downtown that got scheduled for me. And so I'll be heading out a little bit early. Alicia will be stepping in there. And then one final thing, I want everyone to meet Melissa Bacon. I think many of you may know Melissa from her dedicated work in health policy over the years. She's our new deputy director for behavioral health policy, and we're excited that she's joined us. So she's new to the group this week.
Great, thank you, Director. So I want to thank all of you for your time and effort in carefully completing the surveys. I can tell by your comments that you did spend a lot of time and thought, and I really greatly appreciate that. As you are aware, the purpose of the survey was to help us determine which sections are of most interest to all of you, and then based on that to craft our agendas for the next few meetings. So all of you have been provided a copy of a table entitled 340 Review Stakeholder Workgroup Survey Results. So it's on the legal size paper. Those of you joining virtually, this was sent to you along with the meeting announcement. This document summarizes the survey results, and I hope that it will be a resource for you as you participate in the Workgroup's roundtable discussions. I will now take this opportunity to present a subset of that information from the table. Next slide. So I think there's one in front of that. Sorry. Oh, there we go. So as you probably recall, the survey presented 4 types of questions. So in preparing the survey, our staff divided Chapter 340, which has 27 sections, into 8 topical groups. The first question asked workgroup members to rank those 8 groups, with 1 being what the member believed merited the most time and attention, and 8 being the group which each member believed merited the least amount of attention. The second question then asked members to consider each section within each group and to indicate yes or no whether the section warranted workgroup attention. And then for each yes answer to question 2, members were then asked to summarize the challenges or the reasons why they identified that section as warranting workgroup attention. And finally, question 4 asked workgroup members to think about Chapter 340 as a whole, and then to determine which level of priority the workgroup should assign to that particular section. So looking at the results from question 1, we learned that Adam Board's powers and duties, continuum of care, Adam Board's and residential facilities, and Adam Board's organization and size were the 4 top groups of interest, with 68% ranking Adam Board powers and duties as the #1 priority group. Next. So taking a closer look at the first ranked group, Adam Board powers and duties, we see that 340.03 and 340.036 were identified as being of significant interest. 88% for 340.03 and then 80% for 340.036. 340.03 340.03 is a rather lengthy section that specifies in list form the various duties of the boards. And then 340.036 is a section that requires each board to enter into contracts with public and private facilities and community mental health and addiction services providers. It also specifies the parameters around that contracting authority. Taking a closer look at the second ranked group, continuum of care, we see that 340.032 and 340.034 were identified as being of significant concern, 72% and 68% respectively. And this is the group of sections for which we will be having our discussion today. The third ranked group was ADAM boards and residential facilities. 340.031 is a short section permitting an ADAM board to inspect a residential facility located in its service district and to acquire, lease, or enter into a contract to purchase, lease, or sell property for addiction services, mental health services, and related purposes. And then 340.035 authorizes an ADAM board to advocate on behalf of Medicaid recipients and Medicaid eligible individuals. Next section, next slide. And then the fourth ranked group was ADAM boards, organization, and size. I won't go over the substance of each of these sections, but we'll just note that 340.02 generated the most interest within this group. As you can see there, 64%. That section requires an ADAM board to be appointed for each ADAM district and specifies board size and membership. So this graph, I know it's difficult to see probably on the screen, but it will be available on the dedicated 340 Workgroup website for you to see. It shows the average level of priority assigned by the workgroup to each of the sections within Chapter 340, with 1 being the highest, again, of level of priority, and 5 being the lowest. So from the graph on the previous slide, we learned that these are the top 7 sections of highest priority to members. The top section of concern is 340.036 pertaining to board authority to contract for services and supports with an average level priority of 1.92, followed by 340.03, which is ADAM board powers and duties, average level priority 2.28, followed by 340.032, the establishment of community-based continuum of care, average level priority 2.72, and then 340.02 ADAM board organization and size with average level priority of 2.88. And then you can also see then the 5th, 6th, and 7th sections there on the right-hand side, which were the next sections for which people indicated were the highest priority for them. So at this time, I wanted to give members an opportunity to share their reactions to these survey results. And for those of you who are joining us virtually, if you'd like to speak, you can use the raise hand function within Teams. We have Jamal, who says the results are not surprising thematically. Anyone else? Oh, pressure?
Did I do that right? Click on once.
Yeah, that's correct, yeah.
So in our first meeting.
Oh, I'm sorry. Yeah, just try pressing that black button again. Sometimes you have to press it really hard.
Okay, I see it. A light came on.
There you go.
At our first meeting, you know, we had a discussion about like open-ended questions and that kind of thing, and about like overall looking at 340. Are there any overall concepts or things that we want to keep in mind? And, you know, the survey results and the approach that we're taking is taking us directly into the language, you know, directly into the sections. So am I to assume, I'm not passing judgment, I'm just trying to make sure I have the right assumption, that we are not going to have any discussion about if there needs to be any like landmark overall changes?
No, I wouldn't assume that. So we need to have some structure for looking at 340, and the survey and the themes that came out of it are certainly a grounding point for that discussion. But as we look at the section, so the one that we're starting with today is continuum of care. Not going line by line through continuum of care, but more generally, conceptually, what were some of the areas of concern in there? What could be addressed? How can we form the statute to better address the continuum of care approach that we'd like to have moving forward? And so there may be some of that more technical aspect of this is particularly a problem, but there may be more aspirational discussions that we have too.
So I just want to make sure I'm hearing you correctly again. So as we draw out themes from the sections, we'll have an opportunity to say, we have all of these themes that have come out. So what does that mean to the overall statute? That's what I'm trying to say.
Yes.
Okay, all right, thank you.
Yes. Remembering that our intention with this work group is not to redline the current statute and replace it, but to look at the current statute and think about how it's helping us, you know, create that vision in reality for an ideal mental health and addiction services system, prevention, recovery, treatment, the full scope.
Any other thoughts? Yes.
So can you hear me? To the initial question, I'm not surprised by the responses. I think based on other conversations and work we've attempted over the period of years, the results would be exactly what I would have expected. So I think that, this is a great opportunity, that there is, a lot of agreement that change is needed. And so how we go about doing that, I think, is the important work that we're undertaking, and we're grateful that this process is in place.
How
Lori?
about if our virtual participants?
Lori, this is Terry. Appreciate the group and what Teresa just said. However, I do believe the governor's speech that the State of the State speech, should be a major part of this review. Because and I've got a number of quotes I could quote directly from his speech. I'm not going to go through those, but it was fulfilling the promises. The system isn't broken, but it was never developed. Those kinds of things, and he's laid it out, and I guess he's going to have initiatives, and I don't know about those yet, but you're probably coming up with them pretty quickly. We can go through this process, but I think there has to be a foundation. And the foundation, I would ask, I've never, historic in his presentation, I've never heard a governor speak that long in a state to state about these issues, behavioral health. And whatever's in there, and for example, a lot of it is on the most chronic population, obviously NAMI's position, chronic population, et cetera, that the boards must turn their attention to what the governor said in that speech. So however we can lead this to that, but if you don't have that as a foundation, it's just another exercise in changing. Um, I'm really concerned that I've seen that happen time and time again, and at the end, we still don't have a system of care that we all envision.
Hi, this is Sherry. I just wanted to follow up to what Terry said. You know, for a long time, we've talked about, more so in hard times. I mean, right now, let's be honest, we're a little bit flush with money, but we're not always there. But when we get to hard times, we often talk about, it's never really been prioritized who we should serve and how much. And I think maybe a little bit, that's what Terry's getting to, if it's needs to, you know, be the really chronic population, those that are severely mentally ill and severely addicted. But I do think that that's one of those bigger overarching things like Pressure was talking about, that's foundational, that maybe we need to get to really, who are our priorities in this public system? Thank you.
Anyone else? Or move on? Okay, I think we can move on then. Now we will move into the actual roundtable discussion portion of our meeting. And as I mentioned before, today we're going to be focusing on the topic of continuum of care. And again, as the director noted, we're not only going to look at these 4 statutes, but if you have comments, that are more of the big picture, like Prasha was bringing up about aspirational, like where we should be heading, please comment on that as well. So the roundtable discussion is meant to be an opportunity for work group members to share their thoughts on the sections that fall under this topic of continuum of care. And when participating in this discussion, we invite you to consider these questions. These aren't only the other ones, but to think about these as well. So what challenges does this section present? What are its weaknesses? Are the challenges or weaknesses attributed to how the statute is written, or how it is being implemented or enforced, or both? And then how can this section be improved? You also want to have available to you when we're having this discussion the actual revised code sections themselves. These were sent out with the meeting agenda, and for those of you that are attending here in the room, there's copies in your blue folders. Oh, yes. Do we have a hand raised by Tracy Hurd?
Apologies. Yes. Hi.
Okay, thank you.
Good morning, everyone. I'm sorry. But just quickly before we transition, I just had a comment about the last section that we were talking about, and specifically around the comment that was made in supporting the governor, as he's put such attention on this. Do we have, and I'm sure Director Chris is, having conversations about what we're doing here through this 340 exercise, and are there any members of the legislature that are aware of this, who are willing to champion this, or at least be involved in the conversations around potential legislative changes? Because after doing all of this, that's the process that it's going to have to go through, and it would be really great to have some people involved initially who might be willing and interested in championing this on the legislative side, and also within the governor's office. And in terms of the governor's statements, and I apologize, I have to confess, I still have not had an opportunity to listen to the governor's address, but I do want to hear what he said about behavioral health specifically, because I'd like to know if there were any specific shout outs or just a general commitment, if there's something that we can actually respond to. Um, as providers, things that MAC can do around cultural competence and inclusion and those kinds of things. So, in terms of supporting the governor and the governor supporting us, I think we really need to have a conversation with someone from the governor's office and the legislature to make sure that they are aware, and Director Chris, that may well be you. So, that might be redundant to ask someone from the governor's office, but just to ensure that they're aware of our activities here and that there are efforts underway for the behavioral health community to be responsive to the governor's request, so that there is actually action that takes place, improvement, change, versus just us all agreeing we're on the same page. What are we doing about being on the same page? So that was just the comment that I wanted to make. Thank you.
Thank you, Tracy. I can assure everyone that the governor's office is well aware of this work, and the governor, that looking at 340 is something that's important. I think it was even discussed as part of the Recovery Ohio Advisory Council conversations as we looked at just the authorizing structure for the system of behavioral health care. Also in the legislature, these conversations have been around for years, frankly, and right now Representative Swearingen has some legislation that he's introduced in this space. We've been working with him directly. He's aware of this forum and the work group that we put together here, and we're staying in touch with him on that work as well. Also, the Mental Health Caucus is certainly aware of this work too. And so we'll continue to work with the General Assembly, and we can maybe point everyone on the group to our strategic plan, which was developed with great input from stakeholders, people with experience, family members, providers, recovery operators, just the whole gamut, boards, other constituents. That is a real foundation for the vision moving forward too, very consistent with what Governor DeWine outlined in the State of the State. And I do hope you take some time to listen to it or read it. We have that on our website and available through our newsletters. So that's a quick way to access the information.
Thank you, Director.
Thank you. So you can then move into looking at the first section under continuum of care, which is 340.032, which is establishment of community-based continuum of care. And just to give you a short overview of that, this section requires each admin board to establish, to the extent resources are available, a community-based continuum of care that includes specified essential elements. It also requires each board to ensure the rights of persons receiving any of those elements, and that those recipients are able to utilize grievance procedures applicable to the elements. So this particular slide shows the themes of the comments that we received from all of you in your survey responses. And so, I know, you'll also want this opportunity, if you can, to elaborate on those and to share maybe additional thoughts you might have. So at this time, I will start talking and let all of you start the talking for you. Thank you. And again, if you can think of those questions I had on that one slide on what your thoughts are on weaknesses or challenges that statute presents.
Well, go figure, I was gonna say something positive instead of weakness.
I'll do it.
What I was gonna say is, when you look at these themes, I don't see like a laundry list of, we're missing this service, we're missing this service. So I thought that was really kind of a positive, that it doesn't seem to be about the types of services and the scope of services that people all have concerns about. It seemed to be more about the modernization of the language and the clarification of, to the extent resources are available. Some of the things in terms of the themes that were provided, I thought were a little reflective of maybe a lack of clarity of us as a public system. So for example, you know, like this comment about the community plan. You know, that everything that a board does is a public document, the community plan is a public document, like that's completely available to anybody that asks. So, so I thought there were a few things that were like, is it just not clear what kind of an entity we are to people once out there? There were comments about individuals with lived experience needing to be involved in the planning. By statute, we have individuals with lived experience that are on our board. So like at a bare minimum, you can't do anything at a board without individuals with lived experience. You can't do anything because they are involved in literally every decision made at a board. Now, to the extent boards have, other task force and coalitions and other opportunities for feedback and participation in the corrections board, participation in all other parts of the community, you continue to get that feedback from a lot of different angles, but there's never a point in time where the input is zero.
Thank you. We do have a hand raised from Jamal Boyd first, and then Tracy Maxwell Hurd.
Good morning, everyone. Just building off of the last comments, but also just an observation or a thought around a few things that I observed looking at the information and the feedback. One is I think it would be helpful, at least for me being new to the process, to understand how this translates into what needs to be corrected that's implicit and making it more explicit so that it's clear around the revisions and the changes that are necessary. And then how do we implement, how do we operationalize what changes are there and also what is in the code that needs to be operationalized so that then we can track it, measure it, and make sure that we have metrics that lead to results. I think there's a lot of ambiguity around the interpretation of, the language, but also the roles of those engaged in what would need to be implemented. And I think that that's what's causing a lot of the challenges that we've talked about in the first meetings and prior to. So as I think we drive towards clarification, being more explicit about what's needing to be made clear, as well as how do we implement this and operationalize this, but give everyone who's involved their clear lanes to function in so that then we can get, some measurable results done and provide conflict resolution where that may exist.
Thank you. Tracy Maxwell Hurd.
Good morning again. Thank you. I think I will probably only have to make my comments one time because they were pretty much singular in all of the categories that I responded, and that's really around the cultural competence and specifically the class training, and to make sure that that's required for all board members. And that becomes standard requirement for all practitioners, even including that being part of the validation for licensing. I think it's absolutely critical because it impacts the ability for us to be inclusive in providing services, to hear from all communities, from the boards all the way down through those through the frontline service providers, and to make sure that we're directing funding appropriately, that we're collecting data appropriately. That's one of the projects that we're involved in right now. Workforce, to make sure that there is appropriate representation and reflection in the workforce that's providing treatment and those treatment methodologies themselves. Ultimately, we're trying to make sure that all citizens in Ohio, get the best outcomes, but we want to make sure that we're always including all marginalized populations as well and offering services to them according to their needs through approaches that are, culturally and linguistically appropriate for those communities. So I think, those were primarily my comments that I echoed throughout responding to the survey. And that's what I saw most absent. And it's something that I don't think we can assume that people are well-intentioned or we all understand how important that is. I think it has to be prescriptive, and that has to be a requirement that is expected, acknowledged, and noted in the code by the board, et cetera, to make sure that it actually comes to fruition. Because that's part of the challenge that MAC is dealing with right now is, there is no universal understanding of cultural competence, even though we have a state definition of it. There's no universal expectation or understanding of how important this is to service delivery. Um, and the opportunity for the training is there. Of course, sure, we want everybody to come to MAC, but MAC's not the only organization out there doing that. So there's ample opportunity for training to be provided to all, through all levels of people who are contacting people that are seeking mental health services. So I think that's kind of my universal theme throughout the whole thing, but it has to be stated, it has to be prescriptive, and the understanding has to be universal as to how important this is. And not only from directing funding to make sure that all populations are serviced, but long term, this is cost savings as well. Because when you think about people that aren't serviced, who are not appropriately serviced, and what their, pardon, that was my phone, and what the outcomes are from that, all the way up to and including death, that's a pretty high cost that we pay for failing certain populations to, not including them or not adequately servicing them. So thank you.
Thank you. We have some members here in the room that would like to talk. First, Tom Stuber.
And I apologize for not having my computer, but I'll preface this with saying I know we are a home rule state and we value home rule, but I would stress the importance of consistency. The community plan is extremely important, and yet we serve in multiple counties. In one county, we were included and had lots of participation. In two counties, we had no participation. And it was, that's concerning. And I'd like to see some consistency across the process.
And then Michael.
Tracy referenced universal themes, and mine is certainly in my responses to the survey, being inclusive of people with lived experience. And just to talk a little bit about what Prashna brought up, I've heard stories from across the state about maybe people with lived experience being given more of a voice later in the planning process. So my comments are pretty consistent that those people need to be given that voice early on in the planning process so that they really do feel like they're given an opportunity to be heard. Sometimes I think that some of the conversations I've had feel like those conversations or the input by those with the lived experience are almost an afterthought in some instances, and it needs to be made a priority.
Oh, yeah, I've got a couple people here virtually, and then we will get to you. So we have Patrick Tribby has a hand raised.
Yes, just a couple of comments. I think it's all of what we've discussed, I think, are very important goals as we talk about this continuum of care. And, I think I was there when the boards pushed in this to extent resources are available. And it is important, but let's just keep in mind the context of this. If I had 100% control over everything that comes into my community, it would be great in terms of trying to work towards some of these things. But we live in a little different world. 60 to 80% of the services in our community are provided by Medicaid, which I have absolutely no control over in terms of what those services are. Um, Pretty much wholesale in the last 10 years, there's been quite a bit of funding directly from the department to agencies in my community. Again, I have sometimes no involvement in that. I learned, a few weeks ago under a funding stream that an agency had received direct funding from the department on a set of services, which that's your right. It's understandable that that happens, but how do we bring those kind of concepts and discussions into this continuum of care, which appears to be my responsibility when I have no direct involvement or input to some of those things. And that's the real world. I understand that. I mean, with children, probably 80% of the services in our community are Medicaid funded when we focus on the most needy kids and adults. And so as we go through these discussions, I just like for us to keep that backdrop out there to be realistic about what our role is and what I can do in terms of trying to bring continuum of care and some of these things to the forefront in my community. Thank you.
Thank you. We also have a hand raised with Molly O'Neill in the room.
Thank you. I just wanted, is that on? I just wanted to make a sort of impassioned plea around, thank you, around people with lived experience. If it were up to me, the boards would be comprised of all people with lived experience, except we would require one person who was an elected official, one person who was not a person with lived experience, and one person who was a family member of someone who was not a person with lived experience. So I flip it on its head. I think that we have to continue to understand that people with lived experience are not inferior. They are not people to just bring in when we need to check a box. We are people who have a lot to offer and a lot of intelligence and brain trust and ideas. And so I think that it's really important to try to flip the script just a little bit in our minds, if nowhere else, around what does it look like to involve people with lived experience, and what's the importance of that. The other piece is that I think one of the things that our constituents with OCAR continually talk about is inconsistency. So we have boards who are really high functioning and are doing a great job, and then we have boards who are really under-resourced in all kinds of ways. And I think we need to look at that. And Tom was just talking about that, and it would certainly be difficult for a provider, but it's very difficult then, if you live in one of those under-resourced or or areas that seem to be less engaged in this work. Then you are being discriminated against from a system perspective, and I think that's really important to look at. What I appreciate also what Tracy Maxwell Hurd said, and I want to suggest that we have metrics that are around the actual implementation of the equity in our system, and that we have a report card that we have to be accountable to around that. Thank you.
Thank you. And then we will turn it over to Dustin Metz.
Thanks. Just a breath on that, because they're wonderful comments. I want to go back a little bit to what Pat Tribby said with regard to the continuum of care, because I think that term is used in this section is really important, because it can be a community-based continuum of care, which is really what's stated, or the entire continuum of care. And I think people interchangeably use those terms, and they do not mean the same thing. Most of our continuum of care is not provided by community-based providers. So we have this bifurcated system. How do those two systems interact? How do they work together? Are they two separate systems, or are they just simply funding streams that are different, that we fill those gaps? Because I think if we only look at building a community-based system, we are creating two separate systems, which in essence has historically meant a good system and the stigmatized system. We can't have that. We need to have care. And whether you have means or you don't have means, what does that care look like? And there are things that insurance will not pay for that we know is important. So is that a responsibility of the community-based system? Is it something that should be assured across the continuum of care? And having some clarity on those, I think, will give some guidance to providers and boards on what they're doing, as well as we interact with both of those systems. As a provider, we interact with both. So why should it be that one is easier to navigate than the other? Why should it be that there are more barriers placed in front of us in a community-based continuum of care than in just a continuum of care? Is there a reason? Is there something we could do to streamline that in this process? And that community plan, is it a community plan of community-based providers or a community plan? And the responsibility for executing on it doesn't necessarily, if you look at the ship, I mean, who's responsible for doing that in each individual community? It's distributed. So there are models that work, and there are ways that we can look at this and how it can integrate into the whole of healthcare.
Thank you. We also have Teresa Lample who would like to give some comments.
Well, my comments were going to echo what Dustin mostly just said. That's all right. I think, as we've been having this conversation, what's really become clear is the planning and the planning for what is the continuum. We're actually talking more about the planning than what is actually part of the continuum. And I think that's one of the things we struggle with is we have legacy history of how services were organized, managed, from the board level that included all of Medicaid. So it was almost 100% of what we did from a business perspective, from a service delivery perspective. And Medicaid's role has changed dramatically, and now that's all in managed care, and we're doing a different contract management process in terms of how services are funded. But this is really, what is the continuum? And I think we have a pretty actually good definition of what the services need to be. Maybe we need to add a little bit around harm reduction because that's not explicitly called out. But in general, we have a good definition of what the services are. It's really then to the question of how do we create a system or the continuum that's accessible in every community? And then that's where we get then hooked into the funding piece. And I appreciate to the extent resources are available in a board area, but that doesn't result in then serving the needs of the people if they have a service that they need and it's not available because of a resource allocation question, which I think really comes back to what the governor was saying around the system isn't broken, it just wasn't built. We have to really think about how we rebuild it, but there is very clearly a need for planning to make sure that all parts of this are available. And I think that's kind of what we see in the comments. As I was kind of, after I submitted my comments and I was thinking about this, it's almost like this section, and I think the conversation is showing that, needs to be, this is the planning process, and then this is the continuum that's included in that plan. And maybe if those pieces were put together, and organized that way, it would start to make more sense, because it is planning for the full continuum, but not saying it's a responsibility to necessarily fund everything, but making sure that it's available is the piece in the continuum.
Sure. Tony?
I don't know how to do this, so I pray to God I get this mic thing right. Do I push the big black button?
Yes.
Okay. Can you hear me?
Gotta push it till it lights up.
All right.
Can you hear me now?
Woo!
No. I also think, going back to the continuum, I think also, we can't forget about the beginning of the continuum. The calls I get every day, and it says here in 2A of this 340.032, I get calls every day. What do I do? My kid's suicidal. Where do I go? Do I go to the hospital? Do I call a number? Do I have? So, part of the continuum, I think we talk a lot about, folks who are in the system now. What about the folks who have never had experience? And I was one of those parents who, Bryce, my son, went in emergency room. They kept him for 2 days. He's in he's in a hospital, and I, being in the system for 20 years, didn't know what the hell I was going to do for my kid at that point. So also folks who are new to the system, I think, has to be, and again, going back to locating locating persons in need of addiction services and in need of mental health services, I think has to be also considered, and not just folks who are currently in the system.
Thank you. Any other comments? Oh, thank you. That'd be great.
That was the Terry I did. I'm sitting here listening and hesitating to speak because I represent a minute portion of the population of the state of Ohio. And yet Appalachia did get some mention in the governor's address as well. And so I just want to say, as we visit these things, whether it's about the voice of people with lived experience, those are the most difficult positions for me to fill on our board. That may be cultural. That may be the way population is spread out so sparsely across our area. I don't really know. I struggle with it every day, trying to find that piece. We're in our 4th attempt to start a NAMI chapter. It just doesn't take. And we've had the folks from Ohio NAMI there helping us, and we struggle. What is it? Is it cultural? Is it poverty? Is it, what's happening? Because we care very much about that. And so I just want to lend my voice to, as we talk about these things, not to become so prescriptive that we eliminate the ability of certain parts of the state to function. And I don't know how that needs to sound or what that needs to say. It's just that it could easily, if you've never visited my portion of the state, or you haven't lived there or had to function within that culture, it may be easy to look and say, well, you just don't do it right, or you don't have the right attitude, or this is missing, or that's missing. And I'm sitting here, and maybe I should be the expert in the room about that, and I'm struggling with it myself. I mean, we're working with Ohio University about, we need to understand ourselves. We know so little about our own culture, and yet it's emerging as such a strong issue as we try to modernize a system, as we try to offer services that are evidence-based and yet feel helpful to the people that we're serving. So as we speak to this language, I guess I would just ask for, let's try not to be so prescriptive that we make it very difficult for some portions of the state to operate.
Okay, just looking at some of the comments in the chat. So we have, Jamal mentioned that he totally agrees with Tracy, that there should be explicit in each area to ensure that we have a focus on how each code section impacts marginalized communities and individuals. And I know he spoke to that. Thank you, Jamal. And then Samantha Schaefer mentioned the harm reduction call out by Teresa. She says it's essential. Jeff O'Neill mentioned that he really appreciates Patrick Chibby's comments on the realities of how the behavioral health funding environment and mechanisms have evolved and continue to evolve, and how that relates specifically to where board responsibilities lie for planning and ensuring a continuum. Joan mentions that separating the process makes sense. I think that again was from Patrick Tribby's comments. And Cheryl says, I appreciate those comments about challenges in finding some board appointments. I would be interested in hearing what folks' experiences are on that statewide. Molly says, Robin, please reach out to me at OCAR. I would be delighted to help you get people with lived experience in your area to participate.
And anyone else.
Any others that would like to elaborate? Oh, yeah, sure.
I just want to make one additional comment. We talked about individuals with lived experience, and then Tony made his comment about going to the emergency room. I think in the planning, we need to make sure that we're also garnering information from those whose jobs are to help those that have lived experience or needs, and that we can't avoid including them in the entire process. I mean, those that are involved in the addiction provider field and planning field, but hospitals, social service agencies, job and family services, all of those need to be included so that we don't have, I got there and I don't know where to go from here.
Oh, Samantha, did you have something you wanted to share?
Yeah, I was just typing it, but I can speak it. So two things, and I think it was just mentioned. So when I represent a behavioral health organization that now covers 15 counties in Ohio, many of them in Appalachia, and so I apologize. I don't know how the continuum of care is defined at the state, but something that we speak about a lot is making sure that when we're talking about a continuum of care, that we're talking about social determinants of health, and that we're talking about integration with behavioral health, emergency systems, and different things like that. I think we are still fully embracing what we all celebrate, and I think we all agree with that. Wellness has to do with a lot of parts of being human, not just mental health. And so making sure that as we are looking at how we define that we're really taking the whole person into consideration, and that we're truly moving into a space where we're talking about integrated care. And then also just want to say, I view the boards and many of the executives that I get to work with are on this call as great advocates for what we need in our region that we do not have. But not every board has the same resources to advocate or to step up and do that work. And so I know someone had mentioned home rule, and we talk about this in a lot of spaces with children's services and, all kinds of different things in the state. Equity across the state in terms of resources to advocate for what we need in the region to build out our systems of care. It's definitely not there yet, and something we have to create. And just on the harm reduction piece, I did mention that comment, but that falls into what we're talking about as we lean into a continuum of care that takes care of all individuals wherever they're coming to us. So making sure that we, are including, because that includes all kinds of things in terms of taking care of those with substance use and mental health concerns, and all of us as people. So really appreciate Teresa making that call out.
Great, Molly would like to make another comment.
Surprise. The other thing that I think is, that we say, we really think is very important is that we reprioritize some of the resource allocation to the greater extent of the continuum. So in other words, from our perspective, we are allocating 90% of our resources to the first 10% of the process. And we need to look at how we prioritize. And in the planning process, we need to really delve in and look at the reprioritization of allocation of resources to recovery support services, and to the protection of the investment that we make in that first 10% of the process as well.
I was going to add that we have like a litany of different kinds of services in the continuum. But I think one of the things, if we listen to NAMI and we think about how we have very limited levels of care in our system. We have like outpatient and inpatient. They so often talk about, the rehabilitative level of care, like the assisted living level of care, where do we begin to think about that responsibility of levels of care versus laundry lists of various services? I say that because, when I think about the earlier comments, which are kind of in that vein of parity, which I so totally appreciate. But like, I could never list out to an emergency room or to a doctor or anybody else, this is everything that you have to have in your continuum, because new things happen, new ideas come forward, and we don't want to stifle the science of our system to be able to say, this is a great thing to be able to provide and put in place. But we have to be able to respond to the level of intensity that's needed based on the acuity of the person coming in the door. And I think we're a little silent about that, and that prevents us from thinking about building levels of care, and doesn't help us get to the discussion that was mentioned earlier about where does our responsibility lie in relationship to acuity. So.
Thank you. We have a hand raised from Joan England. Joan?
Yeah, thank you. I dropped this into the chat, but I just want to put an exclamation point on what Tom said. So we represent, the MAC represents a wildly diverse set of stakeholders that are interested in behavioral health. And I think I'll speak for myself as someone that's very familiar with the behavioral health system in lots of communities. I think we can get a bit blind to what is available and what isn't available. and think that because we know that services exist, that everybody knows that they exist and they think that they exist in adequate amounts. And when you talk to our courts, when you talk to our schools, our members of the faith-based community, their perspectives on what's available in their communities at times is wildly diverse from what we all think about it. So I think that outside perspective, that community view of the continuum of care and what exists and what should exist is just so critically important. We hear it all the time. Thanks.
Thank you. Patrick. Oh, I'm sorry, Dustin. I'm sorry.
It's okay. I think one of the things that we should probably think about is that isn't necessarily an outsider's perspective. Where is the first place that someone goes? They go to the emergency room. That is an integral part of the behavioral health system. It's an integral part of our system. They're not outsiders. So when we look at what is continuum of care, it's not what do we design and operate. It's how do we interact? How do we work together? How do we facilitate going from different provider types, be it physical to mental health? Is it levels of care? Is it all of those things can happen and be paid for differently? What I think the important thing here is, do we have a functioning system? And I hope that this section, or at least this review, we can get to that.
I want to thank everybody for their comments, and I'm sitting here listening to this conversation and I'm thinking, wow, is my system really focusing on the needs of people with lived and shared experiences? And so lots of different things are going through my mind like right now about how I can improve my process. So this has just been invaluable to me. But one thing I'm sitting here thinking is, who's the continuum for? Is it for us sitting here looking at a linear process of, I'm thinking about my system, wow, I've got this service, this service, this service, this service, and aren't I proud that I have this? Then I'm thinking about the calls I get at the board from people, from family members, from people with lived experience that are consumers going, I don't know where to go, and what I need, you don't have. And so I'm beginning to think, how do I figure out how to satisfy this statute that says I need to have this, versus what people are saying, I know you're telling me that I need this level of care because this is what's being prescribed to me in ASAM because of my addiction issue with opioids, but I'm telling you, I can't make it in the community without residential treatment and they won't let me in. I can't get somebody to pay for it. So when I think if we're really going to look at our continuum, I think we need to look at it through a lens, not only of what makes good clinical practice and good service practice across the many different groups we work with, but also to think about those people we're serving. And I frankly, I don't know how I'm going to even begin to think about this, but I think really this is what needs to drive this. And that's what I'm getting from this conversation, so. You're welcome. I'm a family member myself, and I know there were times that I was trying to get my family member into service, and I'm thinking I have all this years of experience, all these connections, and I can't get anywhere. So, just some thoughts for the morning. So thank you for letting me speak.
Sure, and thanks, Kate, for that, because that's actually, I think between Dustin's comments and yours, that's kind of where I was headed too, is, the continuum can be many things, but it's how do we ensure that we have a healthcare response for all members of our community? And then where there are gaps in people that don't have resources, the resource issue is different in terms of how do we pay for it versus how do we plan for it in terms of it's a healthcare response that we're building for people with mental illness and substance use disorders. I personally don't think it's the board's responsibility to fund everything on this list, but how do we plan to make sure that it's available? Because like you, I've, 20 some years of experience in this field, and I don't have any better luck accessing care for family members than the average person. And that's a very sad statement. But how do we even begin to start with the front door? And is the front door is many times a crisis, instead of how do we move that towards a preventative approach? or a regular occurrence where people can get routine access to care. It's really about planning. I think it's about planning for this and being able to communicate it with all of our community partners about how we help navigate people, how we connect to those services, and understanding, to Robin, to your point, not every hospital is going to do heart transplants. So not every community is going to have the ability and capacity to have everything on this list. But when somebody in the community needs it, how do we make sure that they get to that place that offers that specialty care within our specialty system? I think that's the part in terms of how we think about our systems. We think about it in terms of board areas, and then we end up inadvertently kind of creating walls that are difficult to penetrate when really, if we're a healthcare system, people go all over the place to get access to the level of care and the practitioner that they need. So how do we start to think about that collaboration across to make sure people can get what they need in a reasonable way? Because, it doesn't help if I'm in your county, Robin, and the only available treatment is in Cleveland. So how do we make that? How do we deal with that? But how do we create new opportunities? And how can telehealth help with that too?
I don't really have a mic too close, so now I do, and hopefully it'll work. There it goes. So to piggyback on some of those thoughts, it takes me back to way early conversations about no wrong door to enter the system, right? And so from a client perspective, we're designing it from a board and a provider perspective, right? But where our client comes into a system, whether it is the emergency room or it is a homeless shelter or wherever it is, how is the system designed to connect that person to the services, well, providers will say that they need, but the person themselves is most interested in receiving at that time, because that's how we engage people into service, right? How do we meet them where they are? And if they do feel that they need a residential program, how do we remove those barriers so they can get that particular service at that time? Because the other group, the people that are not getting service, the service system may not be designed to reach them where they are at the places that they are, right? There were, a long time ago, articles on like hot spotters and how do you use community entities that are already in place to engage some of these folks that do want treatment but don't know what the door is to go through, or how, if they start, what is that? When I think about continuum, how do you move me from the ER to the service, that I'm saying that I feel that I need as a consumer in the continuum of care, right? Because my starting point might look really different than Molly's starting point. And how do we keep most of those services at the community level is what I'm really interested in. And there's a piece at the end about rights and grievances. I can't even air my rights and grievances unless I get connected and know what they are, right? And that is another important point for me, like to be able to say, I'm not getting the service I need, and have that honored and work with providers that can help wrap, and I don't mean wrap around in the traditional sense, but wrap around and develop a plan that's uniquely for me to keep me engaged and with me.
I think if I can kind of piggyback off what Amy said, we had a very interesting discussion yesterday evening in a board planning session with the Freedom Center in Knox County. And one of the concerns my providers have right now, and I want to say that we have a very deep respect for our partnerships and a good working relationship with our partners. And we plan very closely together. They're concerned, and I'm thinking about the continuum because I'm thinking who actually drives this continuum process, who makes these decisions ultimately about what ends up in our community available.
Okay.
Yeah.
Oh, sorry about that.
I'm sorry. So, thank you. My concern is, and their concern is, we're beginning to see a lot of very, very large for-profit organizations move into our communities, that we have no control about the type of planning that they provide. We have no control, not only myself, but other members in the community that are just showing up. And I'm not necessarily suggesting that they provide poor services. Please don't misunderstand me. What I am suggesting is they're kind of pushing a continuum about what is available there and how it is people then access into services, which may not necessarily be a way that's within a consumer's best interest necessarily, or a family's best interest. But something to think about is that the people that we're talking about traditionally, when we're talking about our non-for-profit community providers, I think we have to recognize there are other entities out there that are also providing these services. And they may not necessarily follow the same values that we choose to follow, or they may look at things in an entirely different way, which is certainly their right to do. But I think we need to be very cognizant of that too. And that's what you talk about wanting to ensure that services are provided at a community level. When a community loses control of the services that are provided for them, and they can't monitor their quality, they can't monitor their effectiveness, then I think we have a potential for putting our consumers and families at risk. Just something to think about.
Thank you. We have Patrick Tree.
I think the conversation is kind of bent back a little bit in the direction that I've been talking about, and I appreciate Teresa's remarks because it really is not about by board area that we have the control anymore about that continuum, and the last speaker hit on that too, in terms of organizations moving into our community and providing services, which is their right to do. When this top part, modernize the language to reflect who establishes the continuum of care, at least the parts that we have control over. Leaving this the way it is continues to say that the boards have not only the authority, but the ability to control that, and we just don't anymore. Again, I would love to see the Medicaid put in there. I'd love to see the department put in there, that all of us have a joint responsibility in terms of the continuity of care in our community, because again, I only represent 30 to 40% of that with my funding. Some of that is because I have a fairly healthy levy, in board areas where there's no levies, that they have no control in some ways. And I think that as boards, we've struggled to not give that up and feel like if we have that in the language, we've got the control. And we don't. I mean, if we're going to modernize this, let's just take a look, I think, a real look at what's happening in our communities. And Teresa hits on that. Who's in control of this? Is there a process that we recognize some of that or look at that? Because again, funding streams have changed so dramatically. I mean, we just need to be realistic about this as we look at some of these pieces. And I don't have an answer for that, but at least some awareness that, again, as a board, I can't guarantee this anymore. I used to be able to, have a little better impact on that. In 2012 or so, we lost Medicaid. Teresa, you referenced that. At that point, I had almost a 98% control because all of those services came through me. People get services in my community that I'm not aware of. If they're Medicaid folks, they may be in our treatment services, but the other part of the continuum, the housing and some of those things, they're in mine, but I have no awareness about the treatment that they're getting. I don't have access to that data. And so I think some of the parameters that are out there now maybe merit a bigger redesign on some of these continuum of care concepts that we have. Again, I'll stop there. So.
No, thank you. Thank you very much. Tracy Maxwell Hurd. I see your hand raised, Tracy.
Yes, sorry, couldn't get to the mute button. I just wanted to respond to the speaker before, just kind of about how we are able to identify when and where we want to be responsive, and I'm not really encapsulating your comments in full, but it made me think about, in the last speaker as well, data collection. And, that's a project that that our MAC is working with MHAC, Joan England's group as well, around data collection, the absence of it, where it is, where it isn't, et cetera. But that's key to answering all of these questions and really being responsive to all of these needs. So figuring out what data is missing? What do we need to collect to identify where these issues are most prevalent, where hotspots are popping up? Who is it that is best positioned to collect that data? Is it Medicaid? Is it, adding a question on an intake form in a doctor's office, and having a repository that all of those things are uploaded to, figuring out how to manage that through systems that already exist to be able to attain the data that we need at the breakdown that we need, specifically demographically. So, who's collecting it, what it is that we need. These are collective conversations that I think we need to have as partners in behavioral health, all the way from service providers to the payers, et cetera, so that we can make sure we're getting the information and can make the best decisions around allocating resources, again, where those hotspots are popping up and how to allocate resources and services. So, the more that we work on this project, the more it becomes apparent the data collection is key to everything that we're doing in terms of us being able to do our best work in this space. Because it appears when we are failing, it is because we are absent information. We didn't know this population was struggling. We didn't know there was an increase in a certain population in Northwest Ohio, and they have a propensity towards, a certain issue or whatever. So, this data collection is key to everything that we're doing and that we're trying to be best responsive to, from, again, workforce, treatment, funding, and that planning aspect that she was talking about. So, when you're talking about prevention, being more proactive around things, the more data we have, the more consistent we are and more specialized and refined we are in gathering that data, the more proactive we can be. And again, all circling back to that cost savings and best outcomes for everybody. Thank you.
Thank you. Dustin?
Yes. Hello. Okay. I wanted to, just for a second, make sure that we think about one thing, and it's the difference between control and influence. And our system is no longer a system that can be controlled, right? It is provided by everyone. There is no wrong front door. You may be coming in through a school, you may be coming in through an emergency room. You don't control those, right? We don't control them. We'd love to be able to control referrals, that'd be great. We don't, right? So we can influence them. And I think as a system, we need to be thinking about how our boards become implements to influence those external, non-traditional, be they schools, be they whatever, then to facilitate the connections between everybody. And I think that builds a really strong system. But if we do focus on controlling a system, we're going to have some problems, because we're going to have a separate small system and the rest of the world going on around it. And we're at an opportunity in a place where I think we really can move and integrate that all together. I hope we can.
It's funny, you use the word control and influence, which I like. I wrote down, well, first thing I wrote down was purgatory, but I think part of what we're hearing is that concept of expand or contract. I think, part of what Pat, if I'm hearing him correctly, and what people are telling you is that you're right, it's gotten so big. There are so many people involved, which is wonderful. It's more opportunities for individuals to access care. But if we want that influence, how do we expand the statute in such a way that includes those other parties to work with us, plan with us, decide with us what needs to happen with the community? If we're not going to do that, then what do we contract? What do we limit ourselves to? Because monkey in the middle, you just get pulled 10 different ways to Sunday, and you don't have control. You don't have that ultimate say in terms of what's happening. And
The other two concepts that I want to bring up, I really appreciate the concept about data, is that if we're really going to do good planning, we have to open up access to data. We just have to. And I think that one of the concepts that I think, I'm not going to say that it's in our way, but I think is frustrating to all of us is the issue of capacity. So while we may have many services in our communities, we don't have the depth so like if you have home-based therapy, well, we probably need 10 teams, but we're lucky if we can get one. And so sometimes the frustration is, well, I can't get it when I need it. It's about capacity, and capacity is a function of both human and financial resources. And so I just think that's a constant issue that we don't worry about as deeply with primary health, because we assume a level of capacity. And a listing of services is just that. It's just like if you have one, it's not about maybe adequate capacity.
Or adequate quality.
We have some comments in the chat. Molly, you mentioned that there are nonprofits that act like for-profits too, and that quality is a key. Thank you. And you agreed with Tracy on that, and
Data.
on data collection. Amy mentions that she agrees with Dustin, empowering to influence is in the best interest of those we serve. And Joan mentions that the report Tracy referenced is a partnership of MAC, MHAC, Ohio University, and Central State University, that it will be issued in a series of installments beginning this year, and the focus is racial and ethnic equity and behavioral health. I would like to call on Terry now.
Really appreciate what I've heard, but I want to go back to what Pat Trebick talked about. He said in 2012 that he had control of 80%. He doesn't now because Medicaid. When I think as we're really talking about looking at the law and the difference of roles, responsibilities that they had in 2012 to now is completely different. I think the insurance companies with the redesign should be responsible for the Medicaid client. Now, I say that knowing that the rates are not high enough to keep the agencies going the way they did when the boards were funding. But the fact is, they have a responsibility and they should be held to their feet to the fire. So if the insurance plans are responsible for the majority of the Medicaid health care services, let them do that. Where the boards, I think this whole looking at the law is talking about, okay, what do you control, as Pat talked about, and what can you do? And I will say I'm a little concerned, some of the discussion around the different services available for profit, not for profit. To be honest with you, for families and those living with mental illness, these boutique hospitals that have popped up are a godsend. They're our crisis system right now. When they call here and we get 30 calls a day looking for crisis, and now you guys are working really hard on that, and I think we'll have a better system. But right now, they are our crisis system. So I don't have to send them to the emergency room to set for 3 days. But that's a responsibility of the insurance plan. Let them handle that. And then the boards handle what the governor's asked for is a redevelopment of what was promised years ago for the chronic population that now we should all be ashamed are in jails, prisons, on the streets. 80% of caregiving are family members. All of these are the things we should be looking at to change this law, to give the boards the responsibility for those clients that need the care that Medicaid doesn't pay for.
Teresa? Thank you, Terry.
Sure, thanks. You know, as we're sitting here, and I want to go back to the comment that Dustin made around it's not about control but influence. And when you think about that then from a data perspective as well, I think what we're really looking at is how do we shift into a true population health planning mode, where you're thinking about who are the people, what is available. We don't have enough capacity. So to get into a conversation around, you know, the for-profit, nonprofit, I think is a real challenge because we need simply more capacity. We need it to be quality, and I think we have to look at are there different strategies around that, but quality variation happens across the entire healthcare spectrum. So we're not going to control that, but there are things we can do to influence it so that we're driving people towards better quality. But I think the big shift that I see from the planning perspective is how do we really relook at that from a population health planning perspective? Who are the people? What are the specific needs? What is the service array? And then knowing in the full community, and this is a challenge, but it's a big gap, especially I think from that connecting piece that we talked about earlier, of regardless of who my payer is, how do I know where I go to get help before I just spiral down into the depths of my mental illness or my addiction and I end up in an emergency room, or I end up with law enforcement, or I end up in a jail. But that we create that look of who is it that we need to serve in our community? What do we have? And if we don't have it here, how do we connect to it elsewhere? I think that's a real shift from the way our system historically was funded when the boards historically had responsibility for Medicaid and everything that came with Medicaid. Those responsibilities are elsewhere. So the plans have that responsibility, Medicaid has that responsibility, providers have that responsibility from a compliance and everything that goes with that. But then looking at that population health, what do we need? What are the gaps? And how do we work collaboratively from a collaborative perspective to bring more people to the table to help solve those gap problems? Because we can't do this alone, and we shouldn't think that we should do it alone. But I think the boards could really be a bright spot in being the go-to people in every community, that this is where I go, regardless of who my payer is, to get at least connected. And that's something that I think is missing in many communities.
Thank you. We'll move it to Sherry and then Molly, and then I think we'll move on to our next section to take a look at, which is related to this one. But thank you.
Yeah, thanks. I just quickly want to say, I mean, I think getting back to part of Teresa's point has been said elsewhere, you know, how do we integrate all this with healthcare? One of the things we know that in our communities, health departments are doing the CHIPs, the hospitals are doing the SHAW, and we know already that those are big plans. And many of our boards already work very closely with those groups as they are. So in some ways, this issue may be bigger than just us, and we need to look at it like that. And I don't know what theirs is called, but we also know that managed care folks have to put a plan together. So you've got hospitals, you've got community health departments, you've got boards, you've got you know, the managed care plans. And I know the State Department's already looking at some of the SHAW and the CHIP and how do we get in a more synchronized timeline. But it may be that we need to bring some other people to the table. I mean, you talked about little subgroups. It seems like those folks really need to be here if we're really talking about a community plan that's going to pull all of this together. And that doesn't mean each of us won't have our own specialty. Boards would have a specialty for behavioral. Hospitals are going to have a specialty there. Managed care is going to have the bigger picture. I mean, but somehow we have to figure out how to pull all that together, because I think we also sometimes get lost in the fact that there are bigger plans out there that sometimes are more public, when yet our folks are doing some of the same exact stuff. And in many cases are part of those plans as it is. Just a thought.
Thank you. Molly?
I just want to reiterate something that was said earlier and what I said earlier, because I think it's really critically important to people who are working on accessing and or needing to access the system, and that is the quality is priority. There are, in fact, services that are worse than none. there are services that are damaging to people.
That's very true.
So
That's very true.
we have situations where there are, I'm going to pick on recovery housing, where there are funded recovery homes that are demeaning, demoralizing drug houses. We have to have standards. We have to meet the standards. We have to have them be consistent. And we can't just say, well, we don't have any other options, because we do. We have an option to hold people accountable. We have an option to fund quality, and we have an option to stand up the quality services that we know are what are required and worthy of the people who we serve.
Thank you. I appreciate all these comments, and I think we will move then to our next section, which is related to this one, except that it focuses on addiction treatment services and supports. So looking at that particular topic, is there something that you would all like to build upon with this? Sure.
Go ahead, Dustin.
Oh, I'm sorry.
Wait on a mic.
I know why this section got added, and I know the result, and it really needs to be integrated in the whole of what the continuum of care looks like. So I think the conversation we just had includes this, or it doesn't, but it's not a separate section.
Ditto.
Anyone virtually have any comments? Okay, if not,
Sherry.
oh, I'm sorry, Sherry.
You know, and we list, and I don't know that we're there yet, but since we're saying this is kind of all in the same bucket, we talk a lot about recovery housing, and we have for a long time now, but we don't talk as much about group homes and adult care facilities for those folks that are severely and persistently mentally ill. In some ways, they've gotten overshadowed by recovery houses. And don't get me wrong, I mean, I'm in recovery, I think recovery housing is exceptionally important, but I also think we need to start talking about how do we, people in a recovery house are more likely going to be there not for the rest of their life. You know, hopefully they're going to get a strong recovery, they're going to go out. It would not be unusual for an individual with a severe and persistent mental illness to be in an adult care facility or a group home for the entirety of the rest of their life. And we have to figure out how we're going to make sure, you know, Molly's talked so much about quality. Let's talk about quality. But I don't think it's fair to talk about quality in some cases there until we talk about the level of our investment. Because our investment in those homes is much less than what we're investing right now in recovery housing. And we need to figure out a way, and I'm not saying there's enough there even, Molly, but there's less even when we look at some of our adult care facilities and group homes. So I would hope that as we're talking about all this, we make sure that we're not just talking about the front of the system and the middle of the system, but what's at the end of the system, particularly there for those folks that may be there for, like I said, the rest of their life.
Sure.
Sherry, I couldn't agree more with almost everything you said. The only thing I want to be clear about is that it's not zero sum, right?
Yeah.
We never ever want to put ourselves in competition with one another, right?
And I didn't mean to sound that way if I did, I mean, not at all. It's just, I think we have, you know, all those have to rise together.
That's right. Yeah.
Sure.
Just a question. Isn't the responsibility for ensuring quality fall on the licensing body? And do we have a mechanism, well, we do have a mechanism for ensuring that places get licensed, but some choose not to. Is that something that we should be looking at as well, or is that beyond the scope of this committee?
It's a great question, Tom, and I think that is, I think when we first started these meetings, we said there weren't things that were out of scope, and so I think that's something that to be put on the table for sure.
Sure.
And actually, And Tom, it's an excellent point. I want to take it one step further and highlight the difficulty when you have multiple places where you then need to follow through with your accreditation, your certification, your licensure. When you know there's one place that's making sure of that, and everyone can check in at that one place, right? You could go to LACS and determine whether or not a provider is currently licensed to provide those services. That's where it should be. So if there's a centralized place, you shouldn't have to then turn around and do it in multiple places, that you may be held to multiple different standards, so that the one action you perform that meets one auditor's requirement doesn't meet another one, and you have a conflict. This happens. I know that. I'm sure.
And that's another section's in here.
I know, but I think having that centralized place or putting it on the table is a great thing, because it makes everyone's life easier, because you have one place that assures that quality.
Any virtual, Teresa? Sure.
So I think when we're having these conversations, I think the question about quality is essential. I think the question about, is this licensure, is a very different. I would not support licensure of housing unless we're going to license every one of our own homes, and the homes, any type of low income home or other type of housing. So I think we need to really think about, there's a difference. Adult care facilities and group homes are licensed. Housing is housing, and there's a different expectation around housing. We don't go out and regulate permanent supportive housing for individuals with mental health conditions.
We don't?
We don't. We do not license housing. We have residential programs that are licensed. So I think, and then if you really want to have fun with facts, if you think about SUD residential, it is certified,
Right.
not licensed. So we have different standards around what we're talking about that really becomes part of this conversation. We need quality recovery housing. We have processes that to go through an accreditation process, through Ohio Recovery Housing. We could increase the way we think about that, and actually, if you read the standards, you could say you have to have quality. You have to meet quality standards as a condition of being part of the funding, of getting funding. We need a registry. We probably need more in terms of where is, again, back to what is available is a different question than how do we make sure that we're getting funding to those entities that are doing it in a quality way and encouraging and incentivizing quality. But housing, in my opinion, is very different from residential treatment and licensed programming. And I think we just need to be very clear about how we're talking about this.
Michael?
Yeah, I agree with what Teresa just said about the distinction between housing and those programs really that are licensed. But I will say this, and I can offer a unique perspective on recovery housing. I so much appreciate what Danielle does, because I've lived in recovery housing. And when you talk about, and it's something again that Teresa said earlier, about navigability. If we're directing resources to quality housing, how are people navigated to that quality housing?
Right.
Is someone publishing a letter that's saying, well, here's the highest funded recovery housing out there, so that's where your attention should be redirected? No, that's not the case. So all of these decisions need to be made in terms of creating ease of navigability to those quality resources.
Danielle? Thank you, Michael. Danielle? So just
also want to echo what Teresa was saying when we're talking about licensure and things like that with regards to recovery housing. I mean, I totally agree with Molly, as well as with Michael, about it needing to be easier to find quality operators. I know we just did our environmental scan, and I can tell you back up the findings from the scan from my own professional experience, where people call me every day and they just assume that recovery housing is somehow required to be licensed just to exist, like other services are that are offered for people with substance use disorders, and they're often shocked to find out that that's not the case. And I think people, family members or people who experience people in recovery would behave a little bit differently if they knew that there was no set requirement of an oversight entity for in the way that they might think there is when they're making decisions about recovery housing and what housing options that they're choosing. But I also just want to bring up, like for us again, it's housing, echoing what Teresa was saying. And we want this housing to be able to exist in communities of opportunity. And if we start going down the road of, oh, we should license this housing, that makes it not housing anymore. And then all those rights of people who live in the housing under the Fair Housing Act, protections for people with disabilities, we'd be very concerned about them, not having those same rights to locate homes in single-family neighborhoods and areas of opportunity where they can be integrated in the community. And going back to what Sherry was saying, we want people to, when they're ready, some people do live in recovery housing for a long time. They might live there for the remainder of their lives. That's fine if that's what they need. But many people do choose to move out, and we want them to be a part of that community and be able to transition into that community and full participation within their community. And that fair housing protection is really vital to protect the rights of individuals who choose to live in recovery housing.
Thank you. I'm learning a lot since I'm newer to this topic, so I really appreciate this. It's very enlightening. Oh, pressure.
I was just gonna say, I totally agree. But I think the question that people keep bringing up is, how do we ensure quality? And, there are, I call them carpetbaggers. There are individuals and organizations who are taking advantage of very little people, whether they have a mental illness or an addiction. And, in general, those happen to be the entities that have no relationship to a board. And it's like a sour, it's like a bad apple that spoils the whole bunch. And so what kind of the theme I keep hearing is, what's the protection that can be in place to ensure quality, whether it's licensed, certified, or fair housing. If it's somebody that is in need of mental health or addiction housing, they deserve a level of quality, and what can we do to make sure that that exists?
Sure, Sherry, thank you.
I thought that was important, but I also think it's important. I'm going back to what Pressure talked about earlier, so like overarching bigger picture things. I don't think you can talk about housing, whether it's recovery housing, group homes, ACS, without talking about stigma. And one of the things, if we really want to improve our housing system in this state, we have to figure out a bigger way to approach our communities so they understand what it is, what it provides, and what the benefit is to them. Because so often our recovery housing, our ACS, it's a fight to get them in some communities never let them in. So, but basically what Teresa was saying, housing is housing, unfortunately not everybody sees it that way. And I think to really make a big movement in this area, we're also gonna have to look at that bigger overarching issue of stigma and how we get people to really understand the benefits of housing for folks with mental illness or addiction.
Thank you. I see Terry has his hand raised. Terry?
I just want to say that this conversation about adult care facilities and recovery housing is something I'm very interested in. For 20 years, I started the Adult Care Facility Association. The best people I've ever met in my career are adult care providers. They get a bad rap. Yes, there are 20% that are awful, worst people I've ever met in my life are some operators. But whoever was talking about quality, never talk about quality if you're not going to put resources in to create that quality. And that's what's happened because of institutional racism. 80% of these homes that or 60% of the homes that I represent are African American operators. Over 50% of the clients are African Americans, but it's only 13% of the clients in our community mental health centers. Why? Because we don't treat them early and they end up in these homes. And by doing that, we can put them in distressed areas, hide them from the community. Enough is enough. It's time to start supporting these homes and then get the quality. But you can't get quality if you pay somebody less than what you can. For example, RSS right now, 6 years old. The clients get, it was 6 years old when that was passed. The same amount of money they get 6 years ago, they're getting today. Try to live in your home with the cost and try to provide the quality care that we want. And then one last comment, and that is, and people get mad at me for saying this, there are some bad homes, I know that, but what is worse, in a bad home or living under a bridge? And for the mentally ill, that's the choice many times, or death. Thank you.
Thank you. We have Danielle, and then I think we'll move on to the next slide, and then we'll be wrapping up here soon. Thank you.
I mean, I certainly appreciate that comment that Terry made when it comes to housing, and I guess that's the enlightening comment that we know that housing is under-resourced. But I want to continue to echo what Molly said, where we need to keep our eye on quality, and our standards shouldn't just be, well, it's better than living under a bridge. Because people with substance use disorders, people with serious and persistent mental illness, they need more and they deserve more. And that should not be our quality standard. It's better than under a bridge. It should be a safe place where people are supported, where they are able to access the services and supports that they need in the community, and a healthy environment that supports their overall wellness. And to me, that is much, much more than just living under a bridge. And I just don't think that should ever be, our standard of quality. I'm not saying that's what Terry was saying, but I just get frustrated when I hear that, because the solution shouldn't be to lower our quality, it should be to increase our resources. So that way, people should have access to those services and supports. I also want to go back to what we were talking about, where we're seeing within communities, people moving to community providing services that may not necessarily be connected with the board, and then echoing, I think it was Dustin who said it's about control or there's control and there's influence. And I feel like we can take that into the recovery housing or housing context as well. We're just thinking about, well, where are people coming from to access those services? How can we think critically about, not necessarily control, but how can we influence? How can we influence, referrals again going to high quality places? We had talked about funding coming from the board and saying, hey, well, if you want to get board funding, you need to meet certain standards. Well, we know that's not a lot of the money that's coming. I mean, it's coming from all sorts of other sources. And so how can we have, look at all of those areas of influence and use those to increase the quality of the housing? And again, take that market approach where we're constantly referring people to the high quality operators and making sure that those pathways to people are open so that way they can choose high quality services.
Thank you. Thank you, Danielle. Terry, did you want to add something?
I just want to say I agree. It's a terrible standard. Never could we should accept that. But until this system starts providing the funds necessary to provide quality care, we can't criticize the people that are trying to do something, that have hearts and souls. They care about these people. But some of the institutional racism has created this. I just want to make that a point. And we should never accept a person should be under a bridge. It's better than under a bridge. But this is reality. If we didn't have these homes, people are under the bridges. They are today because there's not enough good homes.
Thank you. think we will move on. We have one last section to look at. This was one that wasn't as of highest concern, but I wanted to give the opportunity to, are we out of time? Okay. Okay. So I think at this point then we're at our public comment opportunity time. Do we have any members of the public who would like to comment? Looking at the chat here. I don't see any. I see some members that have commented.
Every Wednesday.
So I think we don't have any members. Yes, we don't have any public comments. So we can look ahead then to our upcoming meetings. Our next meeting will be on Wednesday, May 18th, and the director has proposed that we extend the meeting time for to make it from 10 a.m. to 2 p.m. with a lunch break. During that meeting, we were proposing to talk about Adam Board's powers and duties, as well as the authority of Adam Boards to contract for services and supports. And then at our Thursday, June 30th meeting, again, proposal is to extend it for the 4 hours and then have a discussion on interpretation and construction of 340, Adam Board organization and size, Adam Boards and residential facilities, and then opioids. But does anyone have any comments about that proposal? Sure.
I just have a question. I mean, I think we need more time. I'm not sick at all. But because of where we're at, I think break for lunch is going to take probably a good hour.
They have a cafeteria downstairs.
There's a cafeteria, so
it's.
I was just wondering if we should just maybe go straight through to one, because there's going to be people on Zoom. So I'm not disagreeing at all. We need more time. I'm just trying to look religious.
We'll take that into consideration.
Yeah.
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 There's a cafeteria right there, so.
And also, we think that there wasn't enough time to go through those other sections, so we may rearrange to allow for some additional time to go through recovery housing a little bit deeper.
And are you going to send these slides out to us so we have
Yes.
slides?
Yeah, thank you. Yeah, the slides will be available on our 340 website. Yeah, Danielle brings up that not to cut short our conversation on housing. I think, yeah, that we will revisit this topic. I know it's of great concern. So we also are having, oh, sure. No.
Because there's a lot of things to get through yet. Is there the possibility of an additional meeting at some point?
Yes, there are, yeah. Yeah, the director is considering that. So, in addition, so we have a public comment opportunity also coming up in June. That's an opportunity that members of the public can come and talk with our staff about any concerns they have on Chapter 340. So with that, I think we're at our conclusion. I want to thank everyone. I thought this was a really good dialogue. A lot of very good things to think about as we go forward. And so I really appreciate it all. And please, I want to encourage you, if you have any other additional comments you'd like to make, you're always free to email those to our 340 work group email site. I will be collecting those. So please consider that if you feel like you didn't get to, maybe a chance to say additional things that you wanted to say. So thank you.